all those details into perspective. We do have with us Dr. Girdhar Gyani, who's the Director General of Association of Healthcare Providers, who's joining in to throw some more light on this. Thanks a lot, Dr. Girdhar Gyani, for joining in. Your first thoughts on what you make of this move proposed and the kind of impact that it will have on the hospital industry from an investment standpoint. Does it make the case for a bit of a speed breaker for the kind of investments that are coming in the hospital industry?
Yes. Let me tell you, the Clinical Establishment Act, which Supreme Court is quoting, which came out in 2010, does not provide any reference to the costing. Only the rules which were framed later on in 2012 do mention that central government, along with the state government, should work out the pricing of the medical procedure rather in the range. And that range, of course, obviously will depend upon the geographical location, specialization of the hospitals, and so on and so forth. Now, our contention, we have submitted to the government that we have no problem if this costing is done on scientific basis. In fact, we have suggested that there is an Institute of Cost Accountant of India, which is the statutory body under the Act of Parliament. Let this task be assigned to them and let them work out the range of the cost or the prices of the various procedures, based on which hospital will be able to define or decide the charges within that range. So we have no issue at all. The problem which you are mentioning, that in case central government is unable to do that, then the suggestion of applying CGHS rates, this, let me tell you, this will virtually, I think, will be highly, highly detrimental for the industry, for the simple reason that CGHS rates have never been worked out on any scientific basis. They were worked down on the basis of inviting quotation or tenders from the hospital in 2013, and based L1, that rates were applied across. So obviously these rates are in general 40, 50, 60% lower in most of the cases as far as tertiary care hospitals are concerned. So our request to the Supreme Court is going to be that let these rates of CGHS rates also be aligned with the rates worked out by Institute of Cost Accountant of India.
Okay. So what is the middle ground then, Mr. Gyani? What do you think will probably be a solution which private hospitals can probably work with and which the government can easily propose and will be accepted?
That is, I think, one suggestion could be that let government pick up the rates from the NABH accredited hospitals. Let us say 10 hospitals in tier 1 town, 10 hospitals in tier 2 town, and 10 hospitals in tier 3 towns. Make the average of it. And then, because the patients are coming in bulk from CGHS and from, let us say, PMJY, they can apply a factor of 20% lower. And that rates can be the, rates till we actually get the rates defined by the Institute of Cost Accountant.
Okay, all right, fair enough. But sir, if you could just dwell a little more in terms of how exactly these CGHS rates are come about. They are around 20 to 70% lower. You said that there's a bidding process. Just tell us about, a little more in terms of details about how often are they revised and what kind of considerations are factored in to come to these CGHS rates.
You see, one thing, let me tell you, many times we are asked this question, if the rates are low, why hospitals are impaneling themselves for the CGHS? In fact, there are two reasons. One is our social obligation, that these are meant for the central government employee and pensioners. So we are duty bound to provide service to them. That is one reason. Second reason is because of empanelment with the CGHS, we also get empaneled with the PSUs and some of the leading private entity. And then once we are empaneled with the CGHS, they empanel us in their scheme, but they pay our rates. So that is one reason. Now, second point is around 30% patients come to us from CGHS. and 70% patient come to us from private insurance or from the cash paying patient. So we cross subsidize. So this cross subsidy model works. Tomorrow, if we are asked to say that 100% patient will have to be treated at CGHS, let me tell you very, very plainly, tertiary care hospital will not be able to sustain or survive. So this is the point. Now coming to your other question, in fact, what CGHS does is, in the past also, several times, last time it was revised in 2014, they invite tenders for listing down the procedure. So a hospital with 50 bed will apply, hospital with 350 bed will apply, 500 bed will apply. And you can obviously understand that the procedure rate of 50 bedded hospital will be lower. Now the CGHS will say, okay, to the higher hospital of 500 bed, you do the procedure at the same cost what we have got the quotation from 50 bed. Obviously, it is not viable. Although they try to apply some correction, but CGHS rates.
Okay, all right, Mr. Gyani, very interesting points which have come in from you that, the costing of procedures, most importantly, should be done on a scientific basis in order to come to a consensus possibly in terms of what the rates for private hospitals or standardized rates should be. But we'll take this conversation up in more details, and we'll wait by for any kind of interaction from the government on account of this as well. Thanks very much for joining in and taking the time out. Well, we need to take a short break.